Hi everyone, good morning. I'm Verna Felipe, Coordinator for Educational Programs, and on behalf of ICU-DDR, welcome. We are very happy to have you here with us. Today's webinar, ADHD Medications and Addiction, is the third in our psychopharmacology series. As a gentle reminder, we are requesting all participants to please turn off their microphones all throughout the duration of the presentation. And if you have questions, kindly type it in the chat box and our speaker will address them at the end of her presentation during the question and answer. You can also turn on the transcriptions for the language that you selected down in the bottom. So lastly, this webinar is being recorded. Our speaker for today is a mental health therapist, substance use counselor, and a clinical supervisor. She has been practicing as a therapist since 2003, working with clients experiencing trauma, substance use, and other life challenges. In addition to running her private practice, she hosts the All Things Substance podcast, which helps therapists gain the information they need to add substance use to their scope of practice. She trains therapists and other professionals in a variety of settings. She and her husband have two grown daughters living nearby and live in Wisconsin with their two cats. Ladies and gentlemen, Miss Betsy Byler. Betsy?
Well, good morning, good afternoon, good evening to everyone. Thanks so much for joining us. And we're going to be talking about ADHD medications this morning. Well, this morning for me. And it is something I think that is being talked about all over the place. There's many articles coming out about ADHD because a lot of adults have been getting diagnosed. Technically, ADHD is considered a disorder diagnosed in childhood. And so the adult ADHD diagnosis is kind of new. And there are a lot of folks, I think, wondering if they have it, which brings it to those of us who are interfacing with folks who are struggling with addiction or wondering about ADHD, dealing with mental health issues. And someone just asked me to check the mic. Are we okay?
We are. Sir,
Right.
maybe you would like to check your volume, please. Thank you.
Okay. Just making sure, I want to make sure everybody hears. So with ADHD becoming a more prevalent diagnosis, I don't know that it necessarily means that we have more ADHD, but just that we have more treatment. And with that comes medication. So we're going to be a little brief into things like the science of it and whatnot, because I want to make sure we have enough time to get through what it is I think would be most helpful for everyone. So ADHD didn't become a diagnosis overnight, of course. It started, the first time we ever saw it was 1798, and then again in 1844. In the mid-1800s, there were a lot of books that were morality type books or behavioral type books. And so they came up with Fidgety Phil and Johnny Look in the Air. And over the years, ADHD, which is attention deficit hyperactivity disorder, has started as being brain injured and all the way through until where we are now. And there's all these different names. It became official in 1987 in the DSM, which is in the United States, we use the Diagnostic Statistical Manual as opposed to the ICD-10 or ICD-11 that's used in the rest of the world. So there are three types of ADHD that I want to talk about this morning. And so there's the hyperactive type, the inattentive type, and the combined type. And the hyperactive type is the one that we most think of when we think of ADHD. We think of kids bouncing off the walls and being really hyper and have a lot of energy. And those are very true of a lot of people with ADHD. Having, this excessive physical movement, not being able to concentrate, fidgety. But then there's this other type that kind of tends to go unnoticed. And it's more like a kid being in their own world. And they are spacey and distractible. And I have raised 2 children with ADHD and am married to a man with ADHD. I've raised a hyperactive child and an inattentive child, and I can tell you that they present completely differently. An ADHD child, my youngest, was a constant accident waiting to happen, running into everything on the planet, throwing herself into experiences without looking. My oldest is more sitting in her book reading, sitting in a room reading a book when she's supposed to be doing something else, and certainly cannot do 2 things at once. And it's interesting watching the 2 of them. For adults, it comes out as not finishing projects, moving from one thing to the next, even productive procrastination, where you are doing something, but really you're supposed to be working on this project, but you're like, I'll go clean the garage. And some of this is just human nature, but some of it really is related to having this neurodivergence, which is ADHD. ADHD can be caused by lots of different things. Genetics is a big deal, and there are anatomical changes in the brain that are visible on brain scans. There are some non-genetic factors like low birth weight, premature birth, exposure to toxins. In fact, when they've done research on people who were born with their mothers using methamphetamine, we would think that methamphetamine while in utero would be super damaging. And the research doesn't say that, actually. The most damaging thing in utero is alcohol. But for meth, one of the things they did find is a higher prevalence of ADHD. When we talk about treatment, the gold standard frontline for ADHD in general is going to be stimulants. When kids are really little, like preschool age, we do, I think, find some hesitancy for people to medicate children that age, which is totally understandable. Once they get into elementary school, and so that's, kindergarten through perhaps 6th grade, they're a little more willing to medicate. And then, of course, later on, they're going to have more willingness. And so part of that is they're concerned about growth and whether someone's going to keep growing. I have in my career seen kids who were started on stimulants much younger who are a little small when they're older in stature. But what we know from the research is that typically that growth delay catches up, and it doesn't make any change in what their adult height is going to be. But I think a lot of parents would have some pause about medicating their kids. So we have 2 main classes of medications, and I am going to talk about mainly the stimulants, but I want to highlight the non-stimulants. The stimulants are the one we talk about the most because they work for 70 to 80% of people, which is huge. When we think about psychotropic medications, they don't work at that high of a level. I don't know necessarily what the statistics are for each thing, but pretty much nothing works for 70 to 80% of the people, meaning that not only it has an effect on them, but it has a positive effect and a reduction in symptoms. And so stimulants are a really big deal. We also use alpha agonists to treat ADHD, and they are non-stimulant non-stimulant medications. And then we also use some SNRIs, so the selective norepinephrine reuptake inhibitors. So those are things like Wellbutrin. And so I'm going to be showing you about the different names of medications. You don't need to know all of that. I have it here in case you want that information. But when I get to that place, I just want you to know it's just for your information so that you recognize some of the names. So very tiny little dip into the brain chemistry here. So over on the right, we have a neuron. And neurons are the basic functioning cells in our brain. They are important for everything we do. They get every kind of sensory inputs, they send motor commands, they have electronic signals for everything they do. So me moving my hand right now is all happening by neurons. And the thing about ADHD is the way I think it's best described is it's sort of like having an orchestra. And all of the instruments are the neurons, but there's no conductor. And the neurons are all playing their own tune and doing their own thing. And in between each of these neurons, there's something called a synapse, and that's just the space. And so what happens is they're passing a message from one place to the next, and we end up losing information. And so if the information is supposed to say, focus on this or go do this, and the neurons aren't getting the messages, they're not translating it. And so that's inattention. When they are properly functioning, then attention works well. And this example is for all of us who've been on a train, seen a train. Imagine that synapse is like the vestibule between the two cars. And if they're not securely connected, then we're not going to get the connection that we need. We're going to lose things. And one of the things that happens with these neurotransmitters, and neurotransmitters there's lots of them, but the ones we know the most about in our field of study are dopamine, norepinephrine, and serotonin. And the neurotransmitters are responsible for passing the information, but sometimes a neuron may suck the neurotransmitter back up before it got connected. And then like the connection might have been really good, but all of a sudden the other neuron's like, oh, we're done with that. And so we're having missed messaging all over the place. So when we think about these medications, what they're targeting is slowing down neurotransmitters or releasing more. It depends on what the person's system needs. And that is how we end up kind of transferring medications from one to the other to figure out what a person needs. Whether it's they need more neurotransmitter, they need more of that chemical to send the message, or we need to stop the neurons from sucking all that neurotransmitter up and letting it do its job. And like I said before, again, it works for 70 to 80% of the people. It is not a cure, though. I think, as we know, people aren't going to not have ADHD. We used to say that kids would grow out of it, and I don't know that that's accurate anymore. What we see is that adults don't necessarily have hyperactivity the way a kid would, and I don't know if that is chemistry or society and culture, that it's inappropriate for adults to be running around, or energy levels, that kind of thing. But what we notice now, and what we're finding out with adults being diagnosed with ADHD all over the place, is that perhaps that is permanently there. And I would suggest that it is. We're talking about there being anatomical, visible brain differences between someone with ADHD and someone without. Not deficits, just differences. So when we talk about stimulant medications, remembering that they're the gold standard. They are typically fast acting, 30 to 90 minutes, depending on what it is, and depending on the release schedule. So there's like sustained release, extended release, that kind of thing. And the benefit of them is they don't take a long time to build up in the system. So if someone gets started on Prozac, which is fluoxetine for depression, we're going to take 4 to 6 weeks for that to kick in. It first has to get absorbed into the gut biome before it goes up and works into the brain. And so we don't know if it works. With a stimulant, we can tell pretty much right away, within a day or two, whether we're noticing some increased attention, reduction in symptoms. And so because they are in the system more quickly, they have a shorter half-life. They are sometimes multiple doses in a day are required. I find that in kids specifically who, if their symptoms are a little more pronounced, we need usually to have a dose in the morning, sometimes midday at school. But typically by the time school's over, it's done. And then we get a lot of behaviors. And so a lot of times kids will have doses kind of spaced out during the day. And when you have had somebody like a child on ADHD, you can really tell when the medication's gone. It's kind of remarkable. So there are problems, right? So like high blood pressure is an issue now that we're talking about adults. We want to make sure that when people are going on to stimulant medications, that it's not going to affect their blood pressure. And here are the stimulant medications. So when you look at this, the date of them is when they became widely available, got approved, and then on the market. So Ritalin is, I think, the most well-known for a lot of folks. And as you see, we have two different sections. And there are methylphenidate medications and amphetamines. Methylphenidate are all because they have methylphenidate as their base. So even though Concerta, Daytrana, Focalin, that those are all brand names, they are all still methylphenidate. They're just different combinations and like release schedules and that kind of thing. So a lot of base insurance, like insurance companies are going to say Ritalin because it's of course the cheapest because it's been around the longest. So the amphetamine category is lots of different kinds. So Vyvanse is really popular as a prescription in the United States at the moment. And that is because it has typically a little bit easier time on appetite. It doesn't suppress it quite as much than say Adderall does. But because Adderall's been around the longest, oftentimes that's what's started. That's what people are started on. So these medications work about the same. They have about the same efficacy rates and they have about the same side effect profiles. So when a doctor chooses methylphenidate over an amphetamine, there isn't a ton of reason for it. It's just the one that they've used the most or they've seen the most, that has worked the most for their patients. But we can go, clients can go back and forth from each one, and there doesn't really seem to be a huge difference. At least that's what the research tells us. So they're both effective for treating ADHD. And I added narcolepsy only because they are treated, both of these are used, but narcolepsy isn't necessarily even in the same ballpark, but it is something that these also get used for, which I think for those of us working with people who struggle with addiction, we do need to understand that part. They are impacting norepinephrine and dopamine. And the only difference really is that methylphenidate is said to reach its efficiency a bit faster, while amphetamines tend to last a little longer in terms of duration in the daytime. So again, you do not need to know all of these. These are examples of, this is a lot of medications that are all methylphenidate based. And so they have come up with a lot of ways to put these medications into different release schedules and the way they function. Amphetamines, again, there's lots of different kinds of medications. And so if you have a client, they may switch from a medication to medication, and it's not an odd thing to do in terms of prescribing. So here are some potential side effects of stimulants, which I think we will recognize. So you can imagine putting a stimulant inside someone's body is that we have some sleep problems, appetite suppression, which can lead to weight loss, some headaches and stomach aches. There can be this rebound effect where there's some irritability when it wears off, and then some nervousness. Less common is we have tics, which are sudden repetitive movements or sounds. Some personality changes where someone appearing too serious, and some growth delay. So what I want to make sure that we're aware of here is that the way a stimulant affects someone without ADHD, like I do not have ADHD, and a stimulant in my body is not going to make me concentrate better necessarily. Remembering that orchestra example is that if someone with ADHD, their orchestra doesn't have a conductor. The medication comes in and all of a sudden there is a conductor. And so what's happening is the conductor is able to pull everyone's attention and make sure that everyone's working in the way that they're supposed to be working. And because ADHD is at its heart, what people attend to isn't what they're supposed to be attending to, or they're attending to too many things, and so nothing gets completed. And it can be really frustrating for somebody to be related to, living with, partnered with somebody who has ADHD, because it feels like they're not invested, they're not involved, they're not hearing you, they're not following through on things they said they would do. And that can be really challenging. And it feels like a choice, like they don't care enough, when truly it is not that. The way that their brains function is absolutely different from someone who doesn't have ADHD. And so they can take this stimulant and it will do the thing that someone else's brain does naturally. It will help the dopamine release better, or the serotonin. And so now messages are getting across that gap in their brain and they're not losing those pieces. So someone just asked a question, a couple questions, and I think I will address some of them as we keep going. So I'm going to postpone those, but I did just want to take a quick look at them. So I am going to talk about stimulant medication and meth. So there actually is a form of meth, like actual, that is considered methamphetamine, that's called disoxin, that is available by prescription. And it's not typically prescribed very often, but it is there. I imagine that somebody might prescribe it if they ran through a bunch of other types of amphetamines, and it wasn't working well. But certainly it's not popular, at least in the United States that I'm aware of. But I don't necessarily think worldwide. There are so many other options before someone would go that direction. We are going to see symptoms that look just like ADHD in folks who have used methamphetamines. And there are a number of reasons for that. And we will be talking about that as well. So stimulant ADHD medications are often used by people who have been using meth in order to help kind of ease the period between when they ran out of meth and when they're getting the next hit of meth. So these medications are targeted for theft, diversion, like somebody has a prescription. Over the years that I've worked in agencies, I've had kids report that they weren't taking any medications, but yet it's being filled every month. And so the medication was being diverted to somebody else. And because they are a cheap pie, and it's something that it's not exactly like taking meth, it's not the same at all, but it is the same feeling. And ADHD is one of the diagnoses that ends up looking as though it is a risk factor for addiction. We can say that trauma is a risk factor for addiction, which of course it is. But as for other diagnoses, we don't have the research to say like depression, anxiety, or whatever is a risk factor in terms of we will see it showing up more. But ADHD is. All right, so what's the difference between amphetamines and methamphetamines? So amphetamine is extraordinarily similar to meth, chemically speaking. And the amphetamine part of methamphetamine is the main ingredient in the medications, like Adderall. So meth is amphetamine with an added methyl group at the N position. Now, for most of us, that is never going to come up. It is about how the chemistry in the body works. But there's this methyl group that shows up, and there's two consequences, two impacts that it has on the body. And I need to move my chat. Give me one sec. So the methyl part makes the molecule more lipophilic, which is fat soluble. And things that are fat soluble go across the blood-brain barrier more quickly and at higher concentration. And so where the amphetamine isn't going to necessarily quickly cross the blood-brain barrier, meth will, because of that methyl group. And in addiction and in substance use, that's what we want. I don't know that that necessarily want it in that sense, but when someone is trying to use a substance to get high, they want it to cross the blood-brain barrier quickly, because that is a quicker and faster high. So that's one part of it. The second part of it is that the methyl group has an effect on metabolism. And so it increases the drug's effect. And so let me back up a minute. Here we go. It increases the drug's effect, and it makes it last longer. So remember what I said about, like, some people will need multiple doses of an ADHD medication over the day? It's because it wears off. But with the methyl group, it makes it last longer. And we know that about meth, right? Meth has a much longer high than, say, other stimulant drugs like cocaine. Cocaine is much shorter. Meth has a much longer duration. And it is that methyl group in this equation that makes it last longer. And it does that because of the way it splits off, and it takes longer to eliminate from the body, giving it a longer time for people to feel the high. Someone can get high off of Adderall, methylphenidate, etc. But it's certainly not going to be as powerful as methamphetamine. All right. I do want you to know about non-stimulant medications, because I think it's important. Because there are people who don't respond well to stimulant medications, makes them jittery. It can amp anxiety, which is a huge problem in treating ADHD. When you have someone who has anxiety and ADHD, sometimes you have to choose which one you're going to treat, because you could treat the ADHD with a stimulant and their anxiety could go up. And so they're attending to more things, but now they can't concentrate because their anxiety is too high. Or we can treat the anxiety, and then the ADHD means that we have no conductor in the orchestra, and so they're kind of all over, but they're less anxious about it. And so for a lot of folks who have anxiety, we look at these non-stimulant medications. So for instance, there are a couple specifically that we use that are SNRIs, that's the norepinephrine, as opposed to SSRIs like Prozac, Zoloft, Celexa. Those are serotonin reuptake inhibitors. So one of the most common is Strattera, or atomoxetine, and that's been around for 20 years. And I have seen that work well in some patients and not in others. And it really depends on what type of ADHD, and it's hard to know how that's going to work in their brain. But again, they don't take as long, even though it's not a stimulant, it doesn't take as long for us to see if there's some benefit. And so Qelbree is a newer one that I haven't seen prescribed a ton yet. And so it only came out a few years ago, and we just don't have enough. I haven't had enough information in my own practice. I haven't had enough patients come across my space that have used it. but it is available. So then we have these agonists, and so those are used. So 10x guanfacine is used pretty commonly, and then clonidine. Clonidine can be really sedating, and so a lot of people take it at night, but I have seen it work well. Sometimes I have teenagers. That's one of my specialties, is working with angry teenagers that hate everyone and use drugs. And I have found that clonidine actually does work well. They struggle with remembering medications in the morning, but can remember it at night for some reason. And so I have found that that works pretty well. We also have, sometimes we use antidepressant, that is Wellbutrin or bupropion, and Wellbutrin can sometimes amp people's anxiety, not typically in my experience, but it can. And it is an SNRI. It's just in a different, it's being used off label. So when someone uses Wellbutrin to treat ADHD, that's not what it was, at least in the United States, FDA approved for. That's the federal, the Food and Drug Administration. And then sometimes we do use these tricyclic antidepressants that are older, but it's not as common. But I have seen like imipramine and nortriptyline. I have seen that used some, but I find that it's typically older prescribers that are used to that medication that use it, at least in my experience where I am. So we're going to get into talking about non-medical use of ADHD medications. So abuse of ADHD medications. Part of the reason I think in the field we're moving away from the word abuse is because this is what I've been told. Abuse, the medications themselves are not being harmed, they're not being abused, they're being misused or used in a way that is a non-medical use. And so when I say non-medical use, I mean substance abuse. And that substance abuse leads to addiction. So I do know that the research that we have tells us that non-medical use is increasing, and that there's a wider range of folks who are using it for non-medical purposes. The research studies that I have looked at find that the folks who are misusing this medication, besides the folks who are using methamphetamine, the ones who are using these stimulants tend to be among Caucasian students and among people who have parents with at least one college degree. And they don't tell us why. There isn't causation that we know of. We just know that that's what the numbers are showing. We do know that folks who have these medications often feel pressure to share them, which isn't surprising, I bet. But I know, at least with teenagers that I've worked with, they don't tell their friends a lot of times, because the ones who are actually taking it usually are taking it because they find benefit, and they don't want to not have it because then they're getting in trouble in school. So these are the three main reasons that people have stated as why they are misusing ADHD medications. And it's for improved cognition. The second reason is for recreation, to get high, or to a lot of times combine it with another drug. And it's sort of, the idea is that they want to add it to this cocktail of things that they're taking. Whether it's, want to take it with alcohol or take it with caffeine pills or some other kind of combination. And the last reason was weight loss, but that reason was way down percentage-wise. So that is something, because like dexedrine and some of the stimulants have been things used for weight loss, for appetite suppression specifically, in the 80s. But the two main reasons, percentage-wise, of those in the study were just way more improved cognition, which is about I wanted to take a test. I need to do better at work. I want to be able to function with less sleep, or they're using it to get high. And it just sort of depends on the person. When someone is abusing stimulants, typically they're going to be, they'll start by swallowing it, using it orally, but eventually they're going to typically be snorting it. Technically, you could shoot it up by dissolving the medication, but I haven't seen that a lot. But people who are actively using needles may try that more often, because by the time someone's using intravenously and using needles, using drugs in any other form is kind of like a drop in the bucket for them. And that phrase means that it's like they barely feel it. And that's because intravenous use is the fastest way to get high for most substances. So their body is going to have increased energy. They're going to feel revved up, less need for sleep, lowered appetite, false sense of confidence. And folks with ADHD, this isn't how their body responds. Their body responds with calmness or focus. But it is one of those things that I assume that they can override it, that they could use a whole bunch and maybe have some of this effect, but it really is quite different the way it interacts in their body. So some of the negative effects can be paranoia, agitation, and all the things we think about when we think about stimulants. So increased heart rate, blood pressure, body temperature. And so the body temperature thing is similar to what happens with ecstasy or MDMA, where the body temperature can rise extraordinarily high and dangerously so. And that's not really something that people think about, but it definitely is. When we see bad outcomes from like ecstasy, this is one of the things that we see. Of course, too much stimulant, we're getting the heart moving too fast, everything's amped up, and there can be a risk for cardiac issues, stroke, heart attack, death by stroke, that kind of thing, and heart attacks. So all of the things that we would imagine that a stimulant would do, we're asking the body to run faster and do more than it wants to, and eventually that can be problematic. I've seen this also be problematic with things like medications that are for colds, like dextromethorphan, like Coracetin cough and cold. I worked with a patient once who had some thinning of the arteries in the heart. He was 17 from the amount of Coracetin cough and cold, which they call triple C's, that he had been taking, like 36 pills, which is a box, at a time for an extended period of time. And you just can't ask the system, even though the guy was 17, you can't ask the system to run at that type of level for extended periods of time and not have damage. So with repeated use of stimulants, one of the things we find is extreme anger, suspicion, they're distrustful of people, and sometimes it moves into psychosis. And we have seen that over the years with things like PCP, meth certainly, and people who are using crack when they've moved on from cocaine. It's not that you can't get psychosis ever from cocaine, but it's not as common. But with crack and the repeated use of it, like there is some of that sometimes. And then the withdrawal from it, you can imagine what that is. We've got a big high and now we're going to crash. And so there are fatigue, agitation, nausea, headaches, problems with sleep. So they can be exhausted, but their body isn't really going to allow them to sleep real soundly. Because as the body eliminates the substance from itself, it doesn't happen all in one rush. And if the person's been using in different intervals, then the body's going to eliminate the medication in different intervals as well. But that can interrupt sleep. So the toxicity of it, when someone's using too much, when they're overdosing on it, and by overdosing, we have to determine between, when we say someone overdosed, it means that they took a lot of a medication and they had too much, not that they died. And sometimes we do mean that they died. And so someone will say they overdosed and got medical attention, or they overdosed and they passed away, or they died. And so in this case, we have some concern about people dying from an overdose of stimulants, but remembering that overdose deaths are usually from things like opiates, heroin, because the person has fallen asleep, passed out, they have respiratory depression, and they forget to breathe because their breaths are so few and far between. And so those deaths are quiet and often missed by folks. One of the things that we hear in our field is, when someone's had too much to drink, what do people tell them? Well, they tell them to go sleep it off, right? But that's what happens with drugs too. When it comes to this and stimulants, that's not really the advice, because the person is amped and they are getting more agitated and erratic. And so we don't find overdose in the same way that we do with depressants like heroin and opiates. When there is that, and when we have toxicity, it can impact lots of different systems. So we have the cardio system, of course, the cardiovascular system. The neurological system we can imagine, because the whole point of these ADHD medications is to affect the neurotransmitters in the brain. And so they're supposed to open passageways to, it's like a faucet, right? We're turning on a faucet to increase the flow of neurotransmitters and then closing it down. And we're doing it in a really controlled way with the medication. When someone is snorting medication and taking too much, that's just open. And so, of course, we have neurological and cardiovascular problems. It also involves renal failure, muscular issues, pulmonary, gastrointestinal systems. So it involves a lot of systems when someone is taking stimulants. We put that to adding meth to that just makes the drug get you high faster and last longer. And we know, as we look at folks who've been using meth for a longer time, we can see all of these systems deteriorating in the body. And again, overdose is possible. Things like dilated pupils, tremors, agitation, confusion, hallucinations, paranoia, movement disorders, seizures. So that's where we start to get a lot of risk. Tolerance builds up. And so tolerance is a factor when we're talking about abuse of medications. We're not talking about tolerance in people who have ADHD who are using the medication as prescribed. In my experience and from what I've seen, that really isn't the issue. We're not struggling with tolerance when it comes to this. But when we're talking about our clients who are using, it is a problem. And so now they're taking these stimulants, and then not only are they taking too much, they have to take more and more, which again is going to impact the rate of all of that bad cardiac problems, neurological issues, that kind of thing. And it can turn into a stimulant use disorder. So basically, when I talk about substances, one of the few things I'm going to say is whether or not it has tolerance, whether or not it can be addictive, whether or not there's withdrawal. And so that's basically what I'm saying here. You can have a tolerance to these medications. There is a withdrawal syndrome. It is a diagnosable disorder. There are people whose use of Adderall, Ritalin, whichever, that is their drug of choice. And because it is someone's drug of choice, or it's being used for someone who's in withdrawal from meth and waiting and not able to afford another hit or another bag of meth, then these are stolen a lot. When, at least in the United States, one of the things we have is anytime someone's prescribed a controlled substance, which stimulants are, they're entered into a database so that they can track it, and that's to stop people from going from doctor to doctor, hospital to hospital. And we also require that they only have a prescription for 1 month at a time. So it's a huge pain in the rear to get to be just an average person on these medications, because you have to go and get a prescription every month. And in some places you have to get a written prescription or a physical one. So you bring it to the pharmacy, and that it does, I think they're good precautions, but it is frustrating for folks who need these medications for ADHD. As a parent of someone whose kids took, one of my kids was on a stimulant and the other one wasn't, every month having to go and pick up a physical prescription and bring it to the pharmacy. Not a huge problem, but when you have kids, like, that's just one more thing you're doing. But it is necessary, I think, to keep a close eye on these medications because they are really popular for abuse. When people talk about where they got their Adderall, Ritalin, they say the most common answer is that it was a leftover medication from a family member. And if the person is in school, whether it's secondary school or college and university, they're saying they get it from their friends and that's how they're getting it. They're getting it from peers. So this isn't a typical thing that you go buy on the street. I mean, you can. There are lots of folks when they're dealing numerous kinds of pills, but that's not the most common answer when people have been surveyed about where they get them. So the research tells us that for people who don't have ADHD, it doesn't actually help them academically. So they think it does, but when they've done research on this, so imagine someone at university taking Adderall because they have tests coming up and they want to focus. It doesn't work the same way. And what they found in the research is that it doesn't actually help. And so those people who are taking it for improved cognition don't actually have improved cognition. What they did find is that both amphetamines and methylphenidate actually impairs performance on these, on the tasks of response inhibition, which is thinking before acting. It also impairs their working memory and their cognitive flexibility. And if you think about it, we can imagine why that would be. If you jack someone's brain on stimulants, it's going to be frenetic. It's going to be a little chaotic. It's not helping them focus because their brain's already focusing. They don't need help doing it. And so there's this idea that, oh, I'll just pop some Adderall and I have to study. They feel more energized. So I think that's what leads to people thinking it will help, but it doesn't actually help. So here's where we've come to. We've talked about what ADHD is, where it came from. We've talked a little bit about the huge increase in diagnoses of ADHD. We've talked about the different medications, the non-stimulant medications, and those are typically not abusable. In prisons and jails, people will abuse like clonidine if it's given to an inmate, or Wellbutrin, but I don't know, makes you feel kind of spacey, lightheaded, and I don't know, but it's not a high. But when you, in a lack of alternatives, some people will abuse it to get high, but it's not terribly common. So we've covered all of that, and we've talked about how these medications function. So what I want to spend the rest of our time talking about is treating ADHD in recovery. So as we go through this, I want to make sure that I point out that my use of the word addict may to some seem rude, judgmental. As an addict in recovery, I am an addict in recovery, and I've been sober a long time. And those of us who are in recovery don't see that word as being rude or demeaning. It's something to not be ashamed of. I'm an addict. That is in my blood, and we do recover, and I am very passionate about recovery. And so I want to be really clear, since those of you who have never seen me speak before, haven't heard my podcast, don't know me, know where I'm coming from and what my heart is towards this subject. So my baseline is that anyone in recovery needs to be careful when they're interacting with habit-forming medications. And that could be benzodiazepines, pain pills, stimulants. It really doesn't matter. Anything that's going to have a potential high, a tolerance, a withdrawal factor, anyone in recovery should be cautious about those. And that non-addictive medications should be tried first unless there is a clinically indicated reason. And a lot of times, people who have been using substances do not share that information with their primary care provider, so their doctor or whoever's prescribing for them. Those worlds feel really separate. They also feel really separate from mental health, because mental health therapists, at least in the United States, are not required to know about addiction. It's not part of our licensure. They don't have to know. They don't have to treat it. And so a lot of times folks who are using substances will keep that information to themselves because it's not relevant. And they don't want to tell their doctor because they don't want to get in trouble, and they're afraid that the doctor will turn them into the authorities for abusing medication, which of course they won't. It's against HIPAA. It's a HIPAA violation, which in the United States is that's a health information. Like, you can't run around telling people about someone else's diagnoses or their treatment. So there are non-addictive medications that can treat ADHD. It is important for people to know what substance someone is using, because what substance they have been using is super important. When someone is a stimulant, someone who is addicted to stimulants, I don't believe that there are safe ways for them to be using stimulants for ADHD. That is a personal opinion. I have seen it done, but I really don't think that it's in line with recovery unless the person's untreated condition, if it's untreated ADHD, is so severe that it's impairing their ability to function and to participate in society in a meaningful way. I think it is a slippery slope, and maybe even more risky than that. When you are actively in addiction, you may have people have a drug of choice. They have a thing that they have a drug that they prefer, and that's the one they would want. But in the absence of that, they'll take other drugs. So if someone likes stimulants and they prefer meth and they can't get meth, they'll take other things. They'll freebase cocaine or crack or take stimulants. Or if someone likes downers, depressants, then they like heroin. Well, they can't find heroin, they're going to find other things that have a similar profile. And that's just how addiction works, is that any port in a storm, basically, is the phrase, that they will take what they can. And so I'm very concerned about someone who has an addiction of any kind, but specifically had an addiction and has been a stimulant addict, that I just think it's unwise. Similarly to an alcoholic drinking something that has just a tiny bit of alcohol in it. It just feels unnecessary. And I say that unless there's a clinical reason, because I am not a prescriber. I am a mental health therapist. I am not medical. I've been doing this for over 20 years and been in recovery longer, and I have seen things and how addiction progresses, but I don't pretend to understand all of the medical things. I do believe that there are really good behavioral methods for treating ADHD, which is why we haven't had the diagnoses explosion that we until now, because kids didn't grow out of ADHD. They just grew up and they just figured it out and they came up with strategies. I was speaking with a 65-year-old client of mine and talking about the potential of ADHD. And I asked them about different ways. Well, how do you handle when you have this many tasks, or how do you organize this or that? And what we came up with was she had just come up with a lot of good strategies over 65 years of her life. But her brain still struggled, and it took a lot of energy to come up with those strategies and to engage them, but they are possible. So even if someone's, to me, even if someone is using non-stimulant substances, if they were into opiates, I still think that non-addictive medications should always be tried first. I think I covered, this happens a lot here, but I'm not certain how it is in other places in the world. A lot of places in the United States, I think most, if you're on a stimulant medication, they will require random drug tests. I don't know whether they always follow through with that, but they do. At least require them. You have to sign a contract, and we have to do that here for pain medications, benzodiazepines, anything that is an abusable drug, so that they can make sure that it's in the person's system, that if they're taking a stimulant, it should show up. Now on drug tests, you have to differentiate between meth and amphetamine, because if the amphetamine pops as though it had, what I mean by that's a slang. If amphetamine shows up as positive, that doesn't necessarily mean it's meth. And so, because of that methyl group that we talked about. And so on drug tests, meth will show up as an amphetamine. And so someone could just have that on their panel for their drug test, and they would be able to see, but they wouldn't be able to tell which the person was using. All right. I will respond to comments in just a little bit. So I want to take a few minutes and talk about specifically meth addicts. And meth addicts are often we'll talk about ADHD. And because we know that ADHD can be a risk factor for substance use, it's entirely possible that they had ADHD before they used meth. There are folks who will talk about using meth to treat their ADHD. No one intends on becoming a meth addict. Everyone believes that they'll be able to pull the plug and get out sooner, that they won't become fully addicted to meth. Because in the beginning of using meth, you can sleep, you can eat, you can function. And it feels like you got a new lease on life, because it is euphoric. The problem is that and this isn't necessarily a talk on meth, amphetamine, but because of the way meth works in the body and what it takes from the body, people aren't able to use meth long term to treat their ADHD. So one of the things about people when they're coming off meth is that they are going to feel like they have ADHD symptoms, and they are going to exhibit them. And that is because they have no dopamine in their brain. So the problem with meth is that when they quit, they have their dopamine, depending on how long they were using, their dopamine receptors may be completely destroyed. And here I say that we can't really tell ADHD from meth impact for about 2 years. And there's a reason I say that. And this is why. So when we look at a healthy person, if you look over here on the left, so the red part is dopamine. And remember when we talked about neurotransmitters and that dopamine is one of them, that's what's used in the brain to use the neurons to transfer information. So when someone's been using meth for long enough, what happens is their dopamine receptors basically die and they don't have any. There's like a tiny little bit. If you look in this middle one, the red there is very tiny. And so we're missing an entire group of neurotransmitters. And those neurotransmitters are required for attention, for helping them complete these tasks. And whether it's a muscle, sending it to this muscle, or needing to do a task outside of the body where they're like completing an assignment or whatever, they don't have what they need. And it takes up to 2 years for the brain to heal. And as you see on the 14-month, that could be enough. And maybe those symptoms should decrease. But this is what makes recovery from meth so hard, is that they feel nothing when they quit meth. It's gray and it's really, really hard. And as you can see, there are other problems in the brain. If you look at like the brain, the holes here and in the matter, like it's really challenging. And that ADHD can make those symptoms, whether it's ADHD or not, can be really challenging for them to work through. And so our work in recovery is important, that we're normalizing this, that we're trying to help them come up with strategies for like managing this and staying on top of things. It's also one of the reasons, if you look at evidence-based treatment for methamphetamine, like the Matrix model, the very beginning of treatment is all about scheduling. What are you going to do at what time of day? And treatment is multiple times a week because they just can't retain information. So when it comes to someone who we're treating ADHD and recovering meth addicts, that there are medications that are not stimulant that are available that actually work for a lot of folks. It's not as complete or not complete. It doesn't work to the extent that stimulants work in the general population, where they're working for 70 to 80% of the people. Recovery from the first 2 years of meth is extraordinarily risky and difficult. And many meth addicts find even that they can't take cough medication, dextromethorphan, because it reminds them of using meth. And so I think it's really risky to use stimulants during that time. And there are many options for behavioral techniques and other medications that are safer for recovery. So the final thoughts I have about ADHD, just summing it all up, as I've said, stimulants work really well, and it's super exciting to see in patients when they've been struggling really hard with feeling like failures. They feel dumb and they feel like they can't adult correctly. They can't grow up because they can't, they're missing assignments, or they're showing up late to work, or they're forgetting things, and they're getting in trouble with their partner or family members who are upset with them. And for some of them, these stimulants, they are amazing to see. And so they're really good medications. And there are some side effects that are manageable. I don't know that they're super terrible, but it all depends, of course. Some people can take a medication and it works really well, and other people, it's like poison to them. And so I think the good news is that they are able to try them. People who are getting treated for ADHD can try a medication, and then the next week try a different one if it doesn't work. And I think it gives them more hope that that they can feel better and perform better in their daily lives. So for us, the treating ADHD and recovery, I think, is the hardest part, because recovery is defined differently, and there are many pathways to recovery. I am very familiar with 12 steps. I've been in 12-step programs. I think the steps work well for a lot of folks. I'm not in a 12-step program now. I have a different plan of recovery, but I think there are many pathways to recovery, and they're legitimate. And that recovery has to be defined by what a person needs for themselves. And so that is always going to be what we have to pay attention to, is what does recovery look like for them? What is getting in their way? As we know, when somebody gets sober, they have mental health issues pop up. Lots of folks had pre-existing mental health issues. And if they didn't, which is super rare in my experience, that I think most of the folks I've ever worked with and have had in the treatment centers that I run have had pre-existing mental health issues and trauma. But for those who don't, they tend to develop them throughout when they've been using, because of the life of an addict or an alcoholic and the way that it can destroy relationships and careers and education. And so when someone is in recovery, we need to have their mental health looked at really carefully. And it's not enough to say that they struggle with attention. Depression causes concentration issue. Anxiety causes issues with concentration. So does PTSD. And so when we're talking about someone can't concentrate, we have to look broadly to determine what the cause is, because the stimulant isn't going to work for a person who doesn't have ADHD. It's not going to function the same way. And I think specifically those who are recovering from meth use need to be really cautious about what they're putting in their body, because addiction's hard, recovery's hard. And I think for a lot of folks, they fight for that recovery. And when you get to that, getting to a year is a really big deal, but getting to 2 years it's different. Year 2 is different. And I know that, everyone's like, first year is the hardest. I don't know. It is for some, but also you've already done all the first anniversaries and it's not new anymore. And people are just used to you being sober. And so it's not as exciting. It can be really hard. And especially dealing with meth when you don't have dopamine flooding your brain the way it's supposed to, where things that should be happy don't feel happy. And that's really challenging. And remembering that stimulants in the body doesn't care that you used to use meth. The body recognizes stimulants. And the whole point of a stimulant is to increase neurotransmitter production or slow it down from being taken back up into the cells. And so you get a dopamine hit from it. And that can feel really good and can be really risky. And that is why I say that I think when we're talking about addiction, true addiction, we're not talking about substance abuse where people haven't gotten to an addiction phase. I'm not commenting about that. I'm commenting about people who are full-time, have fully crossed into addiction. I just think it's really risky, and would be cautious with any of the people I work with if they were going to start taking those medications. I would not, of course, advise them medically, because that's not my place, but I will talk with them about risks, just like I do about any other risk that comes up for them. And I do really believe that treating ADHD is super important, and that we need people to be carefully diagnosing and not just slapping a label on somebody. Testing can help a lot. It's really the only objective way to tell if someone has ADHD versus trouble with concentrating from something else. But not everybody has access to testing, of course. I live in a very rural area, and testing is challenging to come by, and it's challenging to get it paid for because it's expensive, but it is the only objective way. So as I realize that we're into question and answer time, I'm going to scroll back up here. So if you have questions, please put them in the chat and I will answer them as I'm able. But we are at the end of the presentation part. So for those of you, especially those of you who need to go to bed because it is super late where you are, please feel free, because that's the end of that. And so Verna, are you good if I read through some questions here?
Yes, please. I think you have addressed some of it, but
Okay, great.
thanks, Betsy.
Okay. So let's see. Someone asked about the current landscape when it comes to access to medications, and there are national shortages of some of these stimulants in the United States. So part of the trouble that we've had in the United States, and I'm not certain other places, but probably so, is we've had shortages of things like Adderall or Vyvanse. And it's very complicated because there are what the companies are capable of producing in a given time and how much they're allowed to produce. Because in the United States, drug companies are given quantity that they're allowed to produce. And to get that increased is long because it's bureaucratic, and anything that involves the government is going to be long. And so it is very hard for the market for production to meet the need because it changes. And medications do expire. So if they open the floodgates and like produce all this Adderall, it may expire and then they're losing out. And of course, financially speaking, they're not going to let that happen. But I do think that there is an increase in the diagnosis of ADHD. We know that for sure. And so they are going to have to, I think, increase limits to keep up with it. Let's see. Someone says, what do you recommend if the client has substance use disorder and ADHD together? Do you have a wait for a remission period? So with meth, it's about 2 years that we see, up to 2 years, where they really can recover that dopamine. When someone is in recovery from other substances, I would say I'm waiting for them to be past withdrawal and kind of the first several months of recovery to see what comes out, because there are going to be mental health issues and we're going to see them. And so what happens when we treat them is, like, sometimes we'll treat someone's depression and they're like, well, I'm not sad, but now I'm really anxious. And that's super normal. Sometimes people are too depressed to be anxious. And so we didn't know that they were anxious. And so we have to kind of keep an eye on what comes out. And it's part of that, really having a therapist or whoever is diagnosing really doing good diagnosing, where they're not just like, oh, smells like depression, we're going to just put a label on it. We need to be sure we know what we're talking about. But I think after a few months where they're starting to feel more normal and getting past the fuzzy feeling from coming off of their substance, I would say we're going to start seeing the symptoms that are going to stick and then work on treating those. So someone asked me if it's this is a private message, if it was advisable to isolate a person with ADHD. And I'm not really sure totally what that person means. But I will comment on what I think they're saying. I think that people with ADHD, and especially students, do need to have quiet and less distraction. So a student with ADHD needs to sit in the front of the room typically. A student with trauma and PTSD looks like a student with ADHD, but they do terribly in the front of the room. They need to sit at the back or by the door. And so those are, because the less distraction does help them, remembering that they cannot always control very well what they're attending to. And so noises, like someone tapping their pencil or their foot or humming or making noises, like their brain is sort of like, let's see everything. And so it's super distracting. And so isolating in terms of putting them alone, like we don't want them to feel punished or sad or like dismissed by others, but we do want to talk with someone about, how is it easier for you to focus? What do you need when it's time for you to get ready for work, or it's time for you to study? Like, what is it that's going to help you? And those are the things that I would talk about. So someone made a comment about that a provider that people who use drugs can be responsible with medication use, differentiating recreational use from medical use, and that they disagree that a provider should withhold a needed medication if they're using in recovery, and that it should be on a case-by-case basis. Certainly, I think it should be on a case-by-case basis. Someone in recovery needs to be able to know for themselves what they can and can't do. My recovery isn't going to look like someone else's recovery. And addiction is addiction. And so there needs to be some understanding of their own addiction and what is dangerous for them. And I believe that, that we want to go with the least restrictive route always when it comes to treatment, medication, and the least harmful, affecting the least amount of systems. And so having non-stimulant, if you have both and both are available and have good efficacy, I'm not sure why someone in recovery would choose for one that has an addictive potential when they don't have to. They might, and that's between them and their provider. What I'm saying is this is, and I think I said this is my personal opinion. This isn't necessarily research-based because we don't have that research, but I'm just very cautious. Recovery's hard won. And I just don't want to put it at risk. And I want people to know they have choices. So I know it's 10, Central Time, it's 9:17. So I'm just going to look at these questions. Verna, is it okay if I look at this last question here?
Sure.
Okay, I'll just be real quick. What skills or techniques do you recommend clients use to manage ADHD and do not wish to take medication? So there are lots of strategies. There's actually a YouTube channel that I really like called How to ADHD. It's a younger woman. She's done a lot of research and connected with some researchers, and she talks about techniques to help her remember things. And it can be what she calls point of use. So when she's going to make coffee, she'll go pick out a coffee cup and then go to get the filters, but then see a coupon and she's like, I need to go to the store, but then see the leash and be like, I need to walk the dog. And all of a sudden she's walking the dog while she's carrying a coffee cup. And so instead, the idea is to put all the things she needs to make coffee in one area so that she's not distracted by all of this. And it's just one little piece. But the thing about folks with ADHD is that their symptoms are in a cluster and they're not the same. But finding out what things that they struggle with, what do they feel like they don't do well enough, or what do their loved ones say to them, and how do we help them? So when I have one of the things I work with teenagers on a lot, and adults, is taking medications, the ones that they're prescribed. I, of course, am not prescribing. I will ask them if they can get a medication reminder, like a box that has Monday, Tuesday, Wednesday, etc. And I'll ask them to fill it and to send me a picture. And then I'll check in with them later in the week. And that is something that I do to try to help them, because I have a medication reminder, a box. I can't remember to take it. I can't remember if I took it, and I don't have ADHD. And so just the techniques are going to be very specific to a task, but I think there are a lot of good techniques on the internet, and we're not talking about, these are going to be the ones that everyone uses, but if people can look at some of those and then some of them they can try and implement and see if they work for them, I think there are lots of folks who have ADHD who can do well without medication. It is very difficult for kids. And so that is a little bit different. My opinion about that is a little different, because as parents and as adults, we aren't the ones who have to live in the kid's head. And we're not the one who has to feel like a bad kid because we can't get our homework done, or we can't, pay attention in class. I don't want them feeling like they're failing if a medication would help. And I know that in the United States, we are seen as being more pro-medication than other places in the world. I've had clients in different parts of the world, and I know that that is the case. I don't know if that's good or bad.
Color brains. On this channel, we talk.
I'm sorry, that's from my end. I was trying to
Yeah.
post
So the How to
website.
ADHD, I recognize the girl's voice, but it's a lovely channel. She does a really nice job. And I would recommend, if you have people in your life or yourself or anybody, check that out. When it comes to stimulants and meth, I do think that there are resources online, but I think you have access to the slides too. If you have any specific questions, you are welcome to contact me through my website, which is betsybyler.com, and I'd be happy to talk with you. So thank you so much, everyone, for showing up at whatever time it is for you or when you're watching this as a recording. And I hope everyone has a great day.
Thank you so much, Betsy. That is a very wonderful presentation. And thank you for our audience for staying. It's very engaging. And Betsy did an amazing job. She has a podcast. If you need to, I am very sure a lot of them is like commending you. So you can follow her on her podcast, All Things Substance. It's there, and we will share with you a copy of the recording link as well as her presentation. And if you have questions, that's her email address. We have another webinar on May 24. I hope that you can join us. And thank you once again for being here. We have, and thank you for supporting ICU DDR's event. We'll see you again next time. Thank you, Betsy.
And Verna, just one quick second. There's this, I have a Google sheet you can access at this link. I typed out the link because if you can't click it in the PDF, but there's 63 different links that to research and articles and things for you. So if you want that, and then for those of you who ask questions that I didn't get to, if it is important enough that you want to talk with me, please email me. It's perfectly fine. You can email me through the website or at betsybyler.com. Be happy to talk with you.
Thank you. Have a good day, everyone, and good night to some. Bye.